You're listening to Innovators, the podcast from Harris Search Associates, where we speak with global leaders in education, research, engineering, and the health sciences, and ask them to share lessons learned as they continue to advance the frontiers of innovation and discovery. Today's podcast will be led by Rick Skinner, Senior Consultant.
At Harris, we've conducted searches for leaders in public health over the past several years. And of late, we've noted a sort of ferment within that field, brought about by people who are almost invariably referred to by colleagues as shakers and movers, and yes, sometimes rabble-rousers. Today, we have the opportunity to talk about public health, and more specifically, the subfield of epidemiology. The latter is, by most accounts, one of the core areas of public health as a professional practice and as an academic pursuit. With us is Dr. Caroline Buckee. She is Associate Professor of Epidemiology and Associate Director of the Center for Communicable Disease Systems in the Chan School of Public Health at Harvard. She earned her Doctor of Philosophy from the University of Oxford, where she was a Wellcome Fellow. She was awarded a postdoctoral fellowship at the Santa Fe Institute in recognition of her and other recipients, and as I quote here, an early career scientists who will develop into tomorrow's leaders in complexity science. Unless such accolades are not sufficient to demonstrate both the breadth and depth of her research, I hasten to note that Dr. Buckee is also involved with the Harvard Data Science Institute. Her work is at once creative and important for dealing with public health problems. In 2013, MIT's Technology Review recognized Dr. Buckee as one of the people under age 35 who were bringing about the next generation of technological breakthroughs and offered the following description of Dr. Buckee and her work. In 2006, during a research trip to Kenya, it occurred to her that the work of another researcher who was doing research with data about cell phone usage might be employed in the service of malaria prevention. What if, she wondered, location data from cell phones were used to intuit a malarial outbreak's point of origin? Locals might then be warned via text messages to avoid the area or use bed netting. Health officials could know where to concentrate their mosquito spray efforts. Indeed, when Buckee pored over data from 15 million Kenyan cell phones, telltale patterns emerged. People who had made calls or sent messages through a certain phone tower were extremely likely to later visit a region near Lake Victoria where malaria wound up erupting in force. The area near that tower was probably the original hotspot and thus where health officials should focus. Buckee and her colleagues are still figuring out the best way to use the data, but the results so far give her confidence that she's found a crucial tool for her work in epidemiology. The ubiquity of cell phones is really changing how we think of diseases, she says. Welcome to Innovators, Dr.
Thank you.
In today's conversation, we hope to bridge three worlds. One is that of academic public health and the study of and education about the prevention of disease, injury, and death. And a second, but very much related, is that of epidemiology. One of, in my view, probably the primary means by which researchers study selected populations to both describe and identify the determinants of disease and death. The third world I want to look at is that of technologies that produce the kinds of information that increasingly allow us to refine studies of public health issues. So I want to begin with public health. Now, you know the history a little bit better, but for our audience, the field as a distinct body of knowledge, methods, and subject matter is really, comparatively speaking, a fairly youthful one in academia. Johns Hopkins began with the first separate school of public health in the United States in 1918, about the time the Spanish flu was coming out. And it was followed shortly thereafter by Harvard and the University of Toronto. According to a 2003 study by the Institute of Medicine, public health in its early days was to be affiliated with the university, very much research-oriented with an emphasis on science, separate from a medical school, and generally stressing a biomedical approach, lab sciences, and infectious diseases. Does that characterization of public health still prevail? And if it's changed, why?
I think that epidemiology in particular, but a lot of the public health sciences are quite different from medical studies and require different education. And they are drawn from a whole range of interdisciplinary subjects. Epidemiology in particular is very mathematical, the study of the statistics of populations, and some of these kinds of approaches that require different kinds of thinking. And I think for infectious disease epidemiology, there is a particular way of viewing the world that is actually distinct from and different from other kinds of epidemiology. So you tend to find infectious disease epidemiologists come from backgrounds like ecology. I trained as a zoologist, sometimes applied mathematics, physics, because we study the nonlinear dynamics that are inherent to contagion processes. And that's slightly different sometimes. The methods we use are slightly different than, for example, trying to identify risk factors associated with a chronic, non-infectious condition. So I think the first thing to say is that we need a different approach that is different from and sometimes unrelated to the training that you would need for clinical medicine. So it is definitely a different kind of science, distinct from what you would learn at medical school. There is an interesting dynamic that's happened, for example, in this country and at Harvard, where for some time, due to the advent of antibiotics and improvements in sanitation and hygiene, infectious diseases weren't really as important. They weren't considered as important because they weren't causing the kinds of mass morbidity and mortality that they still cause in low and middle income settings.
And does that have something to do with the progress that was made with sanitation, so you can move away somewhat?
Yes, absolutely. Exactly, absolutely. So as infectious diseases became less important as causes of under 5 mortality, at least in high income settings, schools of public health, including Harvard School of Public Health, had less and less emphasis on infectious disease and the methods that accompany the study of infectious diseases. But what's happened more recently with the emergence of antibiotic resistance and with an increasingly globalized world, and now, of course, with this pandemic, is we're seeing that infectious diseases are indeed a very key feature of 21st century public health. And so I think that there's been this sort of trend where we saw less infectious disease research in academic science and public health schools, but that has come back now as we've kind of taken a more global outlook and as things like pandemics have started to affect all of us, of course.
If I may, is there a generational difference then in those who are practicing and studying and doing research on public health now and a generation that is perhaps now in their 60s?
I think it depends where in the world you're talking about. So there has been there's been different emphasis depending on the health priorities in different parts of the world. And I think, the infectious disease epidemiology world, it's quite a small field, at least the theoretical side of it. But it has a long history. So it's kind of waxed and waned. I think that there's an important thing that you said about academic public health being about science, biomedical science, lab science. And I think that what we've seen is a growing disconnect between the development of methods and biomedical and technological breakthroughs and the applications of those methods and the translation of the work to public health implementation. Globally,
could you give us an example?
Yeah, of course. So let's just take PCR. Okay, let's just take PCR testing for COVID as an archetypal example, okay? The development of PCR technology really signaled a huge breakthrough in all kinds of areas of biomedical science. And, as a diagnostic test, we can now use PCR to amplify up viral RNA and diagnose somebody as having COVID-19. That technological advance requires lab capacity, it requires financing, it requires technical know-how. And if we imagine parts of the world where people live in poverty and there are remote places where cold chain is hard, laboratory capacity is limited, technical capacity is limited. Translating the PCR test for COVID-19 in those places to actually do epidemiological surveillance becomes extremely challenging and essentially impossible under some circumstances. And so that's just one example, but many of the methods that we're developing are quite sophisticated. They're developed in high income settings with all the capacity assumed. And then when you actually try to implement them and operationalize them, translate them in the real world, there's a huge disconnect. And I think that reflects an inherent tension between, trying to use biomedical research and science and technology to address disease-specific problems and, addressing poverty, the socioeconomics that underlies some of the biggest public health issues in general. There's always that tension, I think, that schools of public health in particular have to try and straddle and understand. And my feeling is that the COVID-19 pandemic has really exposed that gap, has exposed the lack of pipeline to take some of these findings that we've developed in science and actually make them work in the real world. And so I think that's something that we're going to have to grapple with now and in the future.
And it strikes me that that's not going to be something that is just a matter of spending money and building. It's sort of almost a kind of paradigmatic change where you're going to have to think differently about the way in which you get epidemiological data.
Absolutely. And the other thing, I think we have to really change how we think about education, public health training, scientific training. And we have to start, my opinion is that we have to start thinking about the development of both technical and contextual capacity locally. So we have to move from this idea that we have these institutions of higher education that are elite and they train very few people to do a very, high level of technical work. And we have to come up with a much more distributed system for training people and making sure that they are working in situ to solve the public health problems using the science and technology that we have available to us.
You make me think of Hans Rosling, who just died a few years ago, when he was doing all of his wonderful work that actually showed us what data could do to visualize. He himself spent most of his career as a physician in Africa. Yeah. And he once said in one of his talks that I listened to, that much of the research that we were developing people's capacities for were being developed with the expectation, the assumption, if you will, that all of the things that they had in the developed world was going to be had elsewhere, and therefore, but in fact, were irrelevant. You simply could not do the research.
Yes. I mean, if you even look at the cost of reagents, the cost of biomedical research reagents, they are more expensive in low and middle income countries to purchase. There are these sort of just very concrete barriers. The other thing that I think Hans Rosling understood and that I was alluding to earlier is that we tend to overemphasize and over-glamorize science and technology in the absence of local understanding of the social and political context where you're trying to implement it. So there was an editorial written by Seye Abimbola where he talks about problems of discovery and problems of delivery. And, we tend to really fund and award prestige to institutions and people that excel at problems of discovery. So science, technology, innovation. And we haven't yet come to terms with the fact that health, public health, is often much more a problem of delivery, of taking that technology and making it work in the real world, in the place where the problem is, and with local knowledge and context being brought to bear on the whole design of the science and technology to start with. So instead of coming up with a great idea in Silicon Valley or at Harvard and then deciding that you're going to apply it somewhere, rather you have local organizations identify what the needs are and help in the generation of knowledge and in the design of what technology is going to actually help. That does turn the whole kind of institutional structure on its head. Yeah.
This story, I'm sure, is apocryphal, but it's a story of the late 50s, early 60s. The United States, and I don't know the country in Central or South America, but there was a country there that was showing very high rates of infant morbidity as well as maternal morbidity. And they said, if we could just get women not to have babies so often, they seemed to be, they were not unusual for a woman of 16 or 18 to have already had 4 children in some cases. So the idea was that we would go to those areas, and I don't know who funded this project, but the idea was to give them condoms and let them show how we use those condoms, and therefore they would do better. They also observed at the time that the malnutrition problem was a real serious in that particular area of that country. They came back several years later, and the data looked beautiful in terms of outcomes. Everything had sort of moved up, and they were so happy. The only problem was they were still having lots of children. And so one of the researchers asked the question, well, what did you do with all the condoms? And they said, oh, those were great. We stored seeds in them. There's a case where if you'd asked those individuals what they needed to get themselves out of a public health, was they needed to find a way to preserve seeds from one season to another so that they could actually produce food. In point of fact, 5 more years later, so the legend goes, they actually did do that. The number of childbirths went down, but the first stage was simply saying, let's deal with the immediate problem. So your point about context, that sort of illustrates it in a very simplistic way, that unless you understand the context, whatever else you're doing may be fruitless because you simply you're presuming something that doesn't exist.
Yeah, and I think, there are many anecdotes where a healthcare worker has 4 tablets from 4 NGOs and has to fill in forms on each one and, can't charge it. And so, the context is very important. I think there's also something to emphasize here, which is that the epidemiologic transition, which we've understood for some time, before birth rates go down, death rates go down. And that leads, of course, to population expansion.
Yes.
But once you have, overall health and life expectancy improve, people do stop having children, assuming they have access to contraception and so on. So again, this brings back this inherent tension where there's a lot of people in the malaria world feel this tension where it's like, well, if we this is a disease of poverty. So if we could alleviate poverty, then the disease would go away. And that's been an argument and a tension in global health research a lot.
And you see the funding patterns follow that same argument of which comes first.
Yeah, and of course it's circular. So malaria not only is a result of poverty, it also causes poverty and keeps people poor. And so there's, again, how academic science fits into that picture is complicated, and it's changing. And I think it's changing with attitudes around, there's this whole decolonizing global health movement, trying to address some of these hierarchies that have existed because of historical reasons that are inappropriate in the global health world that we live in now.
Exactly.
So I think things are shifting, and I think they're shifting in promising ways, and we need to figure out the best way to take what has been the most remarkable explosion of scientific research and technology. How do we make sure that is globally applicable and is going to help with the overall goal of alleviating suffering?
And that will fly in the face of what we've been saying for almost 30 years in the developed world, and that is we've globalized everything. Don't worry, everything's global now. See, I can show you the person who lives in the Amazonian jungle who has a Nike shirt on, and that proves that globalism. So I see why the change is coming. I also see why it's very difficult to affect that change in a very rapid period of time.
Yes, and I also think that the incentive structure for getting Nike to the jungle is different, and the incentive structure for providing basic healthcare to the same population and the politics around it and how that gets financed is very different. And in many cases, we're still struggling with what is a very resource constrained situation for ministries of health in low-income settings. So it's a different problem.
I want to ask a very long-winded question, so if you need to fall asleep and take a nap, please do so. But it's because I think I was trying to find a way to really understand some changes. Every professional field that I know of in universities undergo some sort of change, largely because the subject matter seems to have changed. Engineers become bioengineers or biomedical engineers. Doctors become geneticists and practitioners of precision medicine, and lawyers delve in deep into forensics. Let me give you 2 examples, and then I'm going to ask my question. Back in 1988, there's this wonderful book called The Future of Public Health. It was done by the Institute of Medicine. It was known then. And it talked about long-standing and very basic public health functions. And all of them were cast in a pretty disturbing light, especially as we looked at what was coming down the road. So the first chapter set the tone for the book in describing the, quote, disarray of public health, in reporting that even current capabilities for effective public health are inadequate, and the health of the public is unnecessarily threatened as a result. 1988. The committee produced the book, and then they went on to talk a lot about the disarray and all that was coming from it. But even then, they even saw new things coming that were more frightening too. HIV/AIDS, the persistent disparity in access to health care and health outcomes for groups of society, the aging of populations, which we never dealt with, and the safety of the fundamental public resources of air, water, soil, and food. So 15 years later, in 2003, the Institute of Medicine took up the work of the 1988 report, and they could cite some progress. They actually cited some progress, but they were less sanguine about observations about the risk of bioterrorism in the wake of 9/11 and the persistence, and that was a word I found interesting, the persistence of many of the 1988 challenges. Not included in the 2003 report was the rapid series of infectious diseases, as you noted, that began to occur, and very few people in the developed world were prepared for. So for the moment, I'm going to pronounce you the National Academy of Medicine. We'll give you an applause later. So you're the successor to the Institute of Medicine. And I want you to put your public health hat on and share us what you see as the public health agenda just for the next 5 years.
Well, first of all, I'm not sure if I'm qualified to answer this question, but let me talk about it in the context of what I do, which is, I think a lot about infectious disease surveillance in particular. So how do we map and monitor infectious disease risks at the national level? So if we just think about the agenda for that little piece of public health, what I think has happened as science and technology has become more and more complex and more sophisticated is that we are seeing increasingly technical requirements for surveillance systems. And what that means is that the human capacity to incorporate new kinds of data, new kind of technology is lagging behind. The financing to make that happen is lagging behind. And it's led to this diverted path between what's possible in theory and what happens in practice, because there's this capacity gap, and it's growing because the possibilities are becoming more and more technical, as you mentioned about the specialization issue. So if you think about some of the work that we do, when I look for someone who's going to work for me to develop methods for surveillance, I want somebody that can use GIS. I want somebody who can work with satellite images. I need somebody that can do nonlinear dynamics modeling. I need someone that understands biostatistics. I need somebody that can easily code and manage databases. These are technical, challenging things that your Ministry of Health in its basic surveillance system isn't going to have a large cadre of people that can do this. And I think that is one of the challenges when we think about implementation of public health science to public health. We need to start to understand and address this increasing technical gap at the implementation level, which a bit relates to what I was talking about before. But for me, what that means for the public health agenda in the next 5 years is this, turning the tables and and thinking about translation deeply, and how we move forward a distributed way of training people in the technical know-how that they need to bring to bear all of this science on the systems that they're trying to push on. Specifically infectious diseases. So even just for malaria, if you think about the technology and the approaches that people are taking now, there's GM mosquitoes, there's, there's lots of mathematical modeling that and mapping, there's a whole lot of different kinds of interventions. The epidemiological data is gathered using digital platforms. These different technical requirements are really hard for a malaria control program that is not resourced very well to manage. And so I think that addressing that problem is going to be a really important part of the public health agenda.
Would I be safe in saying that as dire as that gap, as you described it, as dire as that gap is in middle and poorer countries, it strikes me as it's also coming in very developed countries, because what the curriculum for public health looks like at the undergraduate and graduate level leaves very little space for what you just described, very little space. Where are you going to find someone who has that array of skills and knowledge? That just strikes me as maybe a chasm rather than a gap.
Yeah, it could be. It's definitely not restricted to low and middle income countries. We find it everywhere. And it could be that some of these things can be automated. There are better ways to structure organizationally so that we don't have to, not everybody has to have a PhD, and for sure. But it's about these people that can sit between worlds. And we've really missed them during COVID. The people that can talk both languages.
Exactly. But that's a wonderful phrase. They're between worlds. And I don't think it's hard to fault the individuals themselves for not studying these, when in point of fact, as recently as probably 10 years ago, that wasn't part of anyone's curriculum in public health.
It's a structural problem. And I think that one of the issues that I've seen is it's very hard to get capacity building. How you may not like the term capacity building, but if you know what I mean, it's really hard to get that funded. It's really hard to get long-term funding to train and disseminate people who can, have one foot in both worlds. And I think that I hope that this pandemic crisis will make funding agencies and governments realize how critical it is to have those translational individuals who can work with private industry, work with academia, and work with policymakers, because that nexus is really critical and it's lacking right now. And I think that in public health research, we often make our methods in a vacuum because we're rewarded for publishing papers that are novel and getting grants. And so, that doesn't lend itself to public health work.
No. There is one thing I would say to you, because I made a note in our introduction about you being in the Harvard's Data Science Institute. We just finished several searches in data science. And one of the things we're observing, for example, 4 of the historically Black institutions in the Atlanta area came together to hire someone to run an institute in data science. And their intention is for their undergraduate students to have data science become part of every undergraduate curriculum. That's about as ambitious as I've seen even one university do. To get 4 to do it is even more. But it does suggest to me that the kind of skill level that you're talking about, which at least gets you to the point that you can begin exploring questions like what kind of data and how do we aggregate data from one source to another source, there may be some hope there. But it does strike me that the gap is still pretty fundamental, especially in terms of finding someone to support to what I sometimes call the pipes and the plumbing. I mean, it's hard to get money for that because the question is, why don't they do it? Well, they can't.
Yeah. Yeah, we have one of my grad students jokes that we need data managers without borders, and the tagline would be boring but necessary.
I don't think it'll fit on a T-shirt, so it may be
No,
hard. It may be very hard.
but I think that
I
is
think it's right.
incredibly hopeful, that, and I think it should even start earlier. You know, in
Yes.
my high school, the statistics that I received was really minimal, and I think that, you know, we need to have more statistical data numeracy taught for everyone. Everyone
Every
needs to be
field,
better informed,
exactly.
because this is what is underpinning a lot of the misinformation and the proliferation of misinformation that is making public health so challenging right now, is that people are not numerate. They don't find statistics easy to interpret. And because they haven't had that background, it's very easy to mislead. And I think that's another problem, a general problem with the whole system, is that people need more grounding and more data literacy.
Let me ask one more question, because I know our time is running out. Epidemiology is part of the core of public health, is both a professional practice and as an academic pursuit. And its membership, I think at last count, is one of the largest sections of the American Public Health Association, people who could consider themselves epidemiologists. Your dean, and almost every dean I know of public health in the United States and Canada, background is in epidemiology. Then a couple of years ago, when they really decided, a group came together and decided that they really were going to create something that distinguished epidemiology. So they created the Society for Epidemiologic Research. And with an explicit commitment to something I've never seen before, and that was a commitment to generational change of the membership. In other words, you couldn't stay in there forever. If you came in as a 30-year-old, at some point you'd cycle out. But the notion is that the work that's being done in epidemiology is clearly going to change and grow and become more sophisticated, so therefore there ought to be a way to do it. And he made a point, writing it, one of the founders, Milton Terrace, wrote that the society was founded to provide a common meeting ground for the different generations of epidemiologists and the various categories of specialists in infectious, chronic, and mental disease epidemiology. He also argued at the time he wanted younger people to be able to talk to more senior. It sounds like classic Greek notion of what the university should be. Now, you've won recognition as an epidemiologist, at least in part for the use of new types of data, but also for the development of powerful, and I've actually seen, elegant mathematical models for use in epidemiologic research. What other factors drive the apparent ongoing dialectic of epidemiology? Is it simply the available to more data, or the fact that your desktop computer is more powerful than the one that we used to have as a mainframe 15 years ago? What are the dialectics that push epidemiology and make it so central to public health?
So obviously that's a big question. I've always struggled to even understand what epidemiology is. What do we teach our students in order that they become modern epidemiologists? This is a challenge, because, people that come to epidemiology generally come from all different backgrounds, academic backgrounds, academic traditions, ways of thinking, especially infectious disease epidemiologists, who, as I say, often use very different tools to those that do other kinds of inference. And so I think, the commitment to the rapidly changing description of who is an epidemiologist is something that it's important for us to reflect in our institutional structures. And that is one thing. It's like, well, what does it mean? What does epidemiology mean? It changes quickly. We have new technologies, new data, new sort of interdisciplinary lenses through which we see some of the challenges. One of the things that I think my work has brought to bear on my particular field is the idea that data streams that are unconventional and wouldn't be thought of as traditional health data can be really helpful to understand what's happening in terms of human behavior, human migration, where we might want to allocate resources or collect data to do more traditional epidemiologic studies. But I think that there's an ongoing process where we are continuing to redefine what epidemiology means. One of those processes is breaking down the distinctions between, we've got chronic disease, infectious disease, environmental health, all of these things. But when you work in the real world, you realize that these are intersecting threats that impact people more broadly, communities, and they suffer from all of these things. They overlap, they reinforce each other. And, from a public health perspective, you want to be thinking about the health of a population. And that is complex. It involves multiple different streams of data, different approaches, different kinds of epidemiologic work. So for me, I'm not sure that I even understand epidemiology as a coherent, unchanging, monolithic field. It's not. It's evolving rapidly. And I think that increasingly we understand how these intersecting threats lead to people's health overall. We know that there's more and more evidence that there's a strong interrelation between mental health, physical health, many of the social and political things that drive people to make unhealthy choices intersect with their infectious disease risk and whether they're going to spread a disease more. So understanding community health more broadly is a challenge for the 21st century as we face not just pandemics, but urbanization, pollution, habitat destruction, all of these things. So I think epidemiology is going to continue to be a pillar of health science, and what it really means will change as our world changes.
Thank you very much, Dr. Buckee. If at all possible, we'd like to stay in touch because you're doing really great work. Thank you again for being on Innovators.
Of course, very happy to join
you. Thank you for listening to Innovators, a production of Harris Search Associates. We'll have more insightful conversations with global thought leaders to follow.